My presentation focused around the issues of early MF. And what really constitutes early MF is that low risk, and is that low or intermediate one risk by which criteria? As things have evolved, we have learned that disease burden versus prognostication of survival are really two different things. And I strongly advocated for an individualized approach where we get a better sense of the patient's individual disease burden by splenomegaly, cytopenias, symptoms, etc., and then trying to match that up with therapy. For the current time, in whom to consider ruxolitinib in symptomatic lower risk or intermediate one risk patients, and perhaps in the future as we have more data that becomes available regarding using fedratinib in this group, potentially in combinations with JAK inhibitors with other therapies. So again, more individualized. The concept of early is all in the eyes of the beholder, and a better approach to be mindful of the patient's disease burden when choosing your therapy.